Hello, my name is Dr. Andre Campbell, and I'm going to talk to you about the issue of free air and peritonitis, current approaches to gastric and duodenal perforations. And I'm a professor of surgery at the University of California, San Francisco, School of Medicine. I'm also a trauma surgeon and general surgeon at the San Francisco General Hospital. I do not have any disclosures regarding this topic. I do have a lot of experience dealing with this over the many years that I've been in practice, but I have no disclosures. A little bit of the background of the surgical management of peptic ulcer disease. I'm going to talk about, discuss the approaches to the patient, operative options, and the patient's innovative approaches to this difficult problem. So, peptic ulcer disease affects a lot of people. For approximately 4 million people worldwide, incidence estimated to be 1.5 to 3%. The lifetime prevalence of perforation in patients is about 5%, and the mortality could be wide-ranging. It really depends on where your patients present and how sick they are. We have patients sometimes who are perforated for a day or two, and those are quite sick patients. So the mortality rate can be 1.3 to 20%. The 30-day mortality is in the range of 20 to 30%, and that's because they could have numerous complications afterwards. That includes the leaks, right, and the other complications that go along with being an ICU patient. In the developing world, the patients are younger. They're smokers. In developed countries, patients are more elderly and comorbidities, like in the United States. There's a lot of use of steroids or non-steroidal anti-inflammatories, and H. pylori is quite dominant. There's physiological stress, there's smoking, and previous history of peptic ulcer disease that you get from the patient. So these are things you need to get. So it's important to get a history of what's going on with the patient when they come in, because many times they may have had this problem before and they may not tell you, or you may not ask. It's important to get that information. So the symptoms include abdominal pain. Typically it's upper abdominal, right? And they have bloating, feeling, and fullness. When they're perforated, so when they're really sick, they have a sudden onset of abdominal pain. So they could tell you explicitly when the pain starts. You say, Doc, this thing happened at 12 o'clock and they're here at 2 o'clock in the morning and 2 o'clock in the afternoon. They have perineal signs, so they're really quite tender. And they have the classic board-like rigid abdomen. Plain films can be negative, but the CT scans have 95% sensitivity to help you make the diagnosis. So in terms of other things to do, so there has been some data, although not a lot, on non-operative treatment. These patients are typically not acutely ill, and they've been walled off for several days before they come to you, right? And they may not need surgery. So the management here is NPO and NG tubes, IV antibiotics, right, and triple drug treatment. They must have a study demonstrating no free leak in the perineal cavity. So that's an important thing with this. And the randomized clinical trials and appropriate for patients suggesting a 70% success rate in certain patients. Older data now, but I think that in select groups this may be done. This is not the patients that come into our hospital because typically they present later and they're quite sicker. So whether you can do it open or laparoscopic, and there's advantages with laparoscopy. The decreased risk of wound infection and hernia and better post-operative tolerance. So the shorter hospitalization, decreased post-operative pain, and more rapid recovery. So all the things that go along with laparoscopic surgery. So I think that it's a reasonable thing, and there's been studies I'll share with you in a little while about this topic. If the patient is in shock or they're unstable, you probably should do the open procedure because it's quicker. You can do it fast, and even if you're skilled laparoscopically, if the patient on multiple pressors and they're basically on the verge of arresting, putting a pneumoperitoneum in is probably not a good idea in the patient. But the patients are stable and you have time. I think that it's equally the same, and we'll talk about that in a moment. A little bit about the anatomy, about the duodenum. You can see first, second, third, and fourth portion of the duodenum, and you can see the gastroepiploic artery where the relation is of all the structures in the area where this is at the head of the pancreas. You can see the bile duct right there. So a little bit about open versus laparoscopic, and there's been a number of studies, and really fairly low conversion rate overall, and you can do it safely. You can do it well, and the patients do fine. This is just that study here, And the patients actually do fine with laparoscopy. It's comparable in terms of open versus laparoscopy. So I think that in stable patients, I don't think that there is a problem with doing it laparoscopically. You can get a good washout, you can get a good view, and you can put the stitches in and get the momentum down to over to do your gram patch. There is a way to look at the severity of illness in these patients. It is called the morbidity and mortality, or the BUI score. Right, the BUI score has several things, including systolic blood pressure less than 90, symptoms more than 24 hours, ASA score of 3 or 4, and you can see that here. Morbidity ranges in 17 to 42%, depending on 0, 1, or 2. Right, and the mortality rate goes up. The important thing to remember is if you have a BUI 3 or 4, morbidity and mortality is quite high. For BUI 3, the mortality is 100%, which is kind of hidden in this slide here. So this is a little bit about where definitions are. So type 1 is body lesser curve, right, and it's 50 to 60%, right. It's the same for type 2 when duodenal ulcers and 25%, pyloric or pyloric channel ulcers are 15 to 20%, and a higher and lesser curve is 10%. And anywhere secondary medications can be 50%. So the thing that worry is when you go in, you actually have to find a hole. So if you think they're perforated, you must look. So if it's not in the standard place, pyloric channel or distal stomach, you got to look around. And I've been surprised sometimes when I see these higher up ulcerations on the lesser curve, and I've seen them way up near the GE junction, and it's much more difficult to deal with. We'll talk about operative planning for that. This is what it looks like. Perforated ulcer here. Holes can vary in size, but they can quite be impressive. So type 1, the sick or regional patients, you do a biopsy, a wedge enclosure, right, hemigastrectomy or encompassing ulcer. So there is different discussions about how to do. Do you close? What do you do? So I think that this is reasonable here to excise it, right, because you want to make sure that you don't have a cancer, because obviously you can have a perforated cancer that's presenting that way, and I've had that in some patients. This is the way it looks like. You can do a gastroduodenotomy here, right at the anastomosis here at the lower part. Type 2 or 3, sick or regional patient, the biopsy and wedge enclosure, to a hemigastrectomy encompassing the ulcer, to a shoemaker, and a truncal vagotomy goes along with that. Type 4, large reasonable patient, biopsy, you could do a Poche operation or a Sendi's operation. This is kind of what it looks like here, where you're taking out the stomach, excising. Here, this is what it looks like higher up, and I've had to do this a couple times. Kind of scary when it's up like this, but you can certainly do it. Whether you bring the jejunum up here. Just a picture of what it looks like. The classic subdiaphragmatic free air. You can see that on the left side here, and the CT scan where you can see a gigantic free air in the abdominal cavity. This is what the ulcer looks like when we're doing it open, and this is the gram patch here. I tend not to close the ulcer when I do this, when the pre-pyloric channel or duodenal ulcer. I basically put the patch on, and it usually works in a high percentage of patients. So shock or not, patient history, patient additional word, how long they had symptoms, time since perforation, size. And I would vote if the patient's on wide open pressures and they're really quite sick, just open the patient and do them. And if they're not so sick, you can do it laparoscopically very well. This entity has been described a number of years ago. It's a crack perforated ulcer, the perforated crack ulcers. It happens 2 to 48 hours after smoking crack, and they usually have glass pipe smoking crack. They're 3 to 5 centimeters in size. You do a memento patch, and you treat your H. pylori, usually with 3 drugs for 2 weeks. This is what it looks like here. It's really quite large and quite impressive when you see it. So there's different ways to do it. The Judd Weinberg excised the ulcer as part of the gastropyloduodenotomy, and you close it transversely in 1 layer. I tend to do it in 2, but this is described. Do an angiorectomy and a partial duodenectomy and a B2 to treat the duodenal stump as needed. This is what it looks like with the inverting stitch here, and when you do it in 1 layer. I would tend to do it in 2. That's just my preference. So you can do different things for difficult handling of the duodenum. Routine closure, I'll show you that. The Nissen closure, the Bancroft closure, and the tube duodenostomy. This is what the routine closure looks like in the left upper quadrant here. Right, you can see how we could go down the Nissen closure here. You open up, you go behind the stomach, and you basically you ligate the vessels there. And the Bancroft closure is you mobilize the serosa, right, and you basically close it over the ulcer there, and a tube duodenostomy is the other option. A lot of different factors that goes into this as I begin to kind of wrap things up. Gender, age, comorbidities, steroid use, other drugs, shock, transient factors or disease factors, diabetes or not. So many different factors that go into this thing. So quite complicated as you go through this. So I'm going to try to show you here this video. And what the video shows is what the procedure looks like when you're doing a gastrectomy or an entrectomy when you do a laparoscopically. The first approach is get at the vessels, as you can see there, getting at the gastroepiploic and the right gastric artery and vein as you're doing things. And you can see where the left gastric artery is at as you do things. So once you do that, then the stomach gets mobilized. The stomach is mobilized there, as you can see it. You rotate the stomach up. Once the stomach is rotated up after you've taken down things on lesser and greater curvature, then you can actually fire the staple across the stomach, and you can see that going on here. The stomach is then removed, right? And then once that's done, the stomach is brought down right where the staple line is at, and you actually then join that staple line to an opening of the staple line on the duodenum, right? And by doing that, the stomach stretches down. The stomach will stretch down. You put pressure on it or tension on it, bring it up, and use the staple there to close it off. So that's just a way to do it when you're doing it laparoscopically, and that actually works quite well. So just to kind of give you a show, I mean, many of you do this pretty routinely, but just to kind of show you what it looks like here. So perforated ulcer here, contain perforation, minimal symptoms, condition worse, failed therapy. You take them and you fix it, all right, and you go from there. So conclusion, it's a common problem. The perforation, when it occurs when the patients are profoundly ill, open surgery done and they're really sick, laparoscopically viable and works. You can do it robotically if you want to. I'd like to thank the program committee for asking me to do this talk, and I really appreciate that. I'm sorry they couldn't be there in person. I appreciate you giving me a chance to do that. Thank you so much.